we considered 4 main modifiers that will help us make a more informed and evidence-based decision. So we wanted to look at the number of concomitant impairments that the patient had. We wanted to look at their general or overall prognosis and the possibility that they were going to respond to rehab. We also had to consider the demands of the sport and their own individual demands as an athlete and other psychosocial factors. So let's go through each of these in turn. And again, I'll try and be as transparent as I can about how we reached our rehab decision. So first of all, the number of impairments. So we know that etiological models highlight how chronic instability or lateral instability can be complex in that it's not just about joint laxity, but often the joint laxity can interact with a range of other aspects of ankle function and can manifest itself through lots of different impairments. And these can be things like reduced joint health, reduced range of motion, sensory proprioceptive deficits, altered movement patterns, and muscle weakness. And many of these can pervade proximally to change how the knee moves and how the hip moves and even how the trunk moves. And this complexity is also reflected in both the ROSE guidelines and this 2019 publication by Smith. And each of these provide recommendations on some of the key outcome constructs that you need to consider when you're assessing an ankle and also whenever you're trying to make a return to sport decision. So we followed these as far as our resources and time allowed, and we generated objective data. And this really helped to give us a good solid baseline as to where the patient was in terms of the level and the degree of impairments that they had. So we looked at their subjective function using the FAM Sport. We looked at their feelings of subjective instability using the Cumberland Ankle Instability Tool. We looked at their range of motion in a weight-brain lunge test. Dynamic balance was assessed using a star excursion balance in 3 different directions: anterior, posteromedial, and posterolateral. We counted the number of calf raises that they could undertake in sequence with a metronome, and also looked at their functional performance using a side-to-side 30-second hop test. And the way in which we determined the patient's baseline was essentially just comparing it to the performance on their uninjured right side. So it worked out quite neatly in that all of the previous injuries were to the left side. So the right side had no history of injury and therefore was a pretty good control. And we can see here that in the majority of cases, the performance on the left side was ranging between 65 to 96% of the right side performance. So there's a little bit of work to do. We also just looked at their level of strength and fatigability on hip abduction and side plank tests, and also looked at the resting position of their foot. And again, I would encourage people to always have a quick look at this. So when the patient is in supine, feet hanging off, look at the resting position of their left foot versus their right foot. In this case, the injured left side sat naturally in a little bit more supination.